And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Hello everyone, another week and another great episode, of course, of the Research Works podcast. Thanks for joining us.
Thank you, Dana. It feels like we are moving through this year and this season of the podcast at absolute lightning speed.
It does feel like it. I feel like I'm really planning Christmas.
Don't say that. That is frightening.
It is indeed. And when I think of Christmas, I think of white snow and beautiful, just the real Christmassy feel. Mm-hmm. And I guess in honour of that, we have two people from the Northern Hemisphere who will be experiencing that as opposed to what we'll be experiencing, 40-degree beach weather for Christmas. So we're travelling all the way to the US of A and Canada this time round for our podcast.
Yeah. So on the podcast this week, we have two guests who are co-authors of the paper titled Evidence-Informed Clinical Perspectives on Postural Management for Hip Health in Children and Adults with non-ambulant cerebral palsy. This paper was published in the Journal of Pediatric Rehabilitation Medicine, an interdisciplinary approach throughout the lifespan. So welcome today, Ginny, Paleg and Roslyn Livingstone. Welcome.
Welcome.
Thanks so much.
Thank you. Oh, it's lovely to have you guys join us.
Yeah,
with all the different time zones.
We have managed to coordinate a lot of different time zones and a lot of Zoom feeds, and we're really excited to speak to you both today.
It's such an honor to be on this amazing podcast.
Oh, thanks, Ginny.
Thank you.
Love it.
So we will tell our listeners a little bit more about you both. Firstly, Roslyn, who is an occupational therapist who has worked at Sunny Hill Health Centre for Children in Vancouver, British Columbia, which is in Canada, for over 26 years, specialising in seating, positioning and mobility assessment for children with multiple and complex disabilities. Ros completed her Masters through McMaster University in 2008 and is a clinical assistant professor at the University of British Columbia. Ginny is a physiotherapist and earned her Masters in PT at Emory University in Georgia and her doctorate in PT from the University of Maryland. She started her career at NIH and has worked for her local school system early intervention program for the past 18 years. Combined, Ros and Ginny collaborate and publish content focused on power, mobility, standing, supported stepping, hip health and hypertonia. And what I am hearing from that is that you both have a wealth of experience and knowledge that you can impart on us today.
Yeah, absolutely.
We're so excited to share our work.
I love this because I think when you think about collaborative work between clinicians, like I don't know how many times I sit with other OTs, me being a physio myself, where we just have chats and we talk a lot and talk about so many things. We go down so many different rabbit holes, and I just love that you guys have found each other, collaborated and actually published to put papers out there, because conversations can be great conversations right there and then in the coffee shop, but the fact that you're sharing that with everyone as well in an area where we know that we have a lot of questions around too. So it's absolutely brilliant. Brilliant.
And as we've learned from your podcast, we have the least amount of evidence-based interventions for the kids that are non-ambulant. Yeah. And that's really what we focused on.
Yep.
Yeah.
Absolutely love that.
Yeah. I'm really looking forward to unpacking that all today. But before we start, Ginny, I know you've listened to the podcast before, so you will be familiar with the fact that we do a little icebreaker question before we get into the nitty-gritty of the topic. And today's icebreaker question is, what's the best piece of advice anyone's ever given you?
My person is Frank McCourt. He was my English teacher in high school. He published a novel called Angela's Ashes. And in high school, he told us to be yourself, make it interesting, and write what you know.
Love it.
And I think that's what Roz and I set out to do. We saw lots of researchers publishing things that didn't seem useful to us. And we had questions right in front of us. And we wanted to answer those.
I love it. Yep. Absolutely love it. That's great advice.
It is. And from someone really incredible as well. I've read that book, and it's, that's amazing.
Oh, that's really, really cool. Roslyn, what about you?
Well, I was thinking, just a friend who said to me once, it's okay to show weakness. Yeah. And I think coming from a Scottish background, like you stiff upper lip and you never show that you don't know something. So yes, don't be afraid to show that you don't know things. You're willing to show that we're all learning and exploring. And I think working together with Ginny has really encouraged me to step out of my comfort zone and to be brave and to publish and to realize that I have things to share, and as a clinician that we can show that clinically relevant side and the things that are really important to the kids and families that we work with.
I love that. So and I think, there's a real strength and power in being vulnerable, isn't there? And kind of putting yourself out there and I totally agree with that.
Yeah, I love that. Wow, I think we've all gone quite deep, and I've got one that's quite deep and I've got one that's not so deep. So my one that's quite deep is, we are what we repeatedly do. Excellence, therefore, is not an act but a habit. And I love that even just within the context, we think about that personally in our lives. If you want to be joyful, then you'll be joyful, and you do need to practice doing that sometimes. You need to, my predisposition was always like glass half empty probably, and that was just practiced. But you can turn things the other way around through just constantly doing it and practicing. And then I think about what we do for our work, as a physiotherapist, we are what we repeatedly do. And there's a context for that as well, learning new skills, or, we're going to talk about postural management as well today. There are things there that I just love. So that's my deep one that I absolutely love. My other one is, if you don't have time to pick up the mobile phone, just leave it. If it's important, they'll leave a message. And that one saves me a lot of times.
Very practical
so
advice.
That's more
I love
practical,
it.
What about yours? I'm always curious where these come from.
Oh, well, I was actually surprised that we hadn't got around to this question yet on the podcast. I thought it was time to bring it out.
Yeah,
there's lots of things. I think I probably have a more serious one and a more lighthearted one. And I think the serious one is probably, again, a practical one. And it was something that one of my previous supervisors explained to me, and I understand why they did that. And it was, if you're going to bring a problem, at least try to bring a solution as well. And I think it's advice that I've carried with me throughout, my working life, but also, my personal life as well. And I think, taking positive action, helps to overcome a lot of the hurdles that we face.
So true. So true. Yep.
And the other one, which is from a colleague who I used to work with, and he was a professor, before he retired, or still is a professor, but he's retired now. And his advice was always, don't take yourself or anyone else too seriously. And so I try to do that as much as possible.
Those are really good ones. I love it. It's really practical. Oh, gosh, that's very inspiring. Good question. I really like this one.
Great.
Really, really good one. And you're right. I'm surprised we haven't gone through this one earlier. Yeah. Right. Well, now that you've all been hopefully inspired by these great thoughts that we've had and advice that we've received, let's jump into this paper. So we all know that for individuals with cerebral palsy, particularly classified within GMFCS levels 4 and 5, require postural management. Whether it is sitting, standing, lying or stepping, there are just functional needs to consider, as well as comfort and participation. So the purpose of this paper is to synthesize the evidence regarding the use of postural management to positively influence hip health in children and adults with cerebral palsy functioning at GMFCS levels 4 or 5. Now, as there isn't high-level evidence within this area, Therapists and families are often left with so many questions about the potential effectiveness of their efforts, as well as how to decide, which pieces of equipment to purchase. So this review brings together the current state of the evidence, as well as some great takeaways for clinicians and families that we can all implement.
I love that. I'm looking forward to getting to that bit.
I'm so excited.
Let's start with a kind of a broad introduction for our listeners, Ginny and Ros. And can we talk a bit about children and young adults that present with cerebral palsy and who are classified within GMFCS levels 4 and 5? What are some of the clinical features that they present with?
I'd like to start with the variation, because I think people look at the pictures that come with the GMFCS levels and they forget the incredible amount of variety. So I have known children who at GMFCS level 4 who can take a few steps.
Yep.
But they're still GMFCS level 4. Yeah. And I know kids at GMFCS level 5 that can drive their power chair, that can step in their supported stepping device, but yet they're still GMFCS level 5.
Yeah. Mm-hmm. Yeah. That's actually such a good point. Yeah.
So many people are I know a number of therapists who are always like, well, they must be GMFCS 3 because they can walk with, a walker with forearm supports and they can take steps across the room. But then when you look at their actual function from day to day, like primarily they are wheelchair dependent. And Ginny always says it's not a smorgasbord. You can't pick and choose the items. You're all one thing or another.
Mm-hmm.
Yeah, I think what I've been pitching for a long time is using the GMFM to check your work. I was horrible in math. I did horrible in those problems where you had to check your work. But I know that when I go back to the GMFM and I plot the centile on the chart, or I use the software, I like to do it by hand because I like to see it. Yeah. So I can say, I have a child right now that I'm trying to decide, are they a 4 or 5? Because they're a 30th percentile 4 and a 90th percentile 5. And they're really riding the fence. And I have to think about, well, this child has had so much care, so much intervention, so much participation, so much leisure activity, so much activity. Really, I think they're a really good 5. And we've almost crossed them over to have some 4 skills. But when I think of their risk for hip problems, I really have to think about them as a 5.
And just their equipment needs and the as you said, Ginny, the risk factors, the postural asymmetries and the contractures that come on early when we think about postural management equipment. I think as young adults, the data that's coming out of CPUP in Sweden is really showing that sort of 60 to 90% are needing support to maintain a symmetrical lying position, and all of the adults are using the supportive equipment in sitting, and so that equipment is often needed to improve their function, and so that can make them quite different from someone who's really a true level 3.
Yeah. So I suppose what I'm hearing from you there, like I love how you brought up the variation that you will see between children who may be, GMFCS 4, a little bit of skills possibly in 3 and 5, but we do need to actually understand which levels they are, because we need to then think about, what are the risk factors. And you just raised there, Roslyn, about contractures and Ginny, you talked about, then we need to think about their hips, because they are different and there are some different strategies there. One of the things that I loved in your paper that you wrote was that because of the contractures and the possible asymmetries as a result of their different movements they may have difficulty initiating movement themselves, and there lies a significant risk. Can you talk to us a little bit about that?
Well, just because they're needing equipment to be in those different positions. Without equipment, often people think, oh, well, in lying, that, sleeping position, they should be free to move. They need to be free to move on the floor. But the reality is that most of these kids, it starts very, very early. They have preferred positions, maybe because of the muscle pool or just the way they have the positions they can control. And typically they end up in those positions for long periods of time and not be able to to change out of those positions. So it's not, people think of it like themselves, we lie in bed and, I toss and I turn and I change from one side to the other. But if you can't change position, you have to think about how that feels, how painful that is if you're lying in one position, and how stiff you get, and that you can't change position. So requiring support to keep you in an aligned position, and then needing help to perhaps be changed to a different position, that can be really challenging. And what the data shows, I think one of the first studies, Fulford Brown, shows that picture of a baby, and the baby lay in a certain position, and then you see the person as they got older, and you can see their posture, their scoliosis, the windswept hips, all the deformities went along with how they were predominantly in that position. And I've seen so many kids that you can just tell by looking at them which position Mom held them in. Sure. So in her arms, they were held in that position. They weren't comfortable lying down. You see so many kids that can be a problem. So finding equipment that can make them comfortable and allow them to function, I think that's where the key is, rather than focusing too much on, we're not trying to perfect their shape, we're trying to make them comfortable, and we're trying to make them functional and able to participate.
And I think that probably leads really nicely into my next question, which is about the ICF and how we use the ICF to try and understand the impact of these different things that you're talking about on a person's life. So how do these features that we're talking about here fit within that classification system?
I'm going to take this question because I am the F word girl. I'm all about the F words.
So Ginny.
Love it. And some of the F words that Peter didn't write about. I have a dress with all the F words. I'll be wearing it in Las Vegas at the AACPDM because we are presenting 2 papers. We have a scoping review on early interventions for the kids at level 4 and 5, not with Roz. She's not in that group. It's an international group. And we sorted by the F words. So we actually have published a protocol paper about how we did that. And I think as I listened to Sarah Reedman, Sean Williams, Kathy Morgan, Iona Novak, all these people that we are following, Michelle Jackman, when we talk about how are we thinking about the ICF, one of the things I learned is that the F words don't directly correlate to the ICF. They're richer things. And when we went to go sort the ingredients, it was really hard because they went in all different places. And one of the things that Roz and I talk about in our spare time is, where does the assistive device go? Is it an environmental? My other group thinks it goes more under family. We think, though, in the end, as our conversations with Peter Rosenbaum have surfaced, is that they could go anywhere. And it's really about how the family and the child are using those devices to improve their participation and their functioning. So if anyone's been following these podcasts, we all are shifting away from focusing on body structure and function and fitness. And really going more towards participation and friends and family. And we put postural management and hip surveillance and hip issues under future because we're trying to prevent deformity. Wonderful. We're trying to prevent dislocation. We're trying to prevent pain.
And so, that really highlights again this, the importance of postural management when we're talking about the future. These children all grow and become young adults, and with that becomes increasing complexity and challenges in terms of managing their posture. So can we talk about that a little bit more and what postural management looks like?
Well, it's often called 24-hour postural management, and it's really thinking about all the activities and positions and equipment and a total program, thinking about all the 24 hours, because, we talked a little bit about lying positions and what a problem that can be if you can't change position or if you're always stuck in a harmful or asymmetrical position. And in the past, people didn't really think about how much of your lifetime is spent in that position that might be the worst position that you're in terms of your body and maintaining that. And it's been traditionally thought to be more about body structure and function. You're thinking about alignment, you're maintaining the hips in abduction, keeping a symmetrical posture, good for breathing, all that kind of thing. But I think it was really when we were writing this paper that it really struck me that when you think about maintaining and sustaining positions, that's really at the activity level. So postural management programs are intervening more at the activity level, and we're trying to really think about having more of a focus on the child's participation and their function, because if you're not comfortable, if it doesn't work for the family, if it doesn't allow them to participate in desired activities, then nobody persists with it. That's just the reality.
Gosh, that's a lovely summary of it. And I think that's why there's so much value and importance on this. And so let's just go through some of the detail now, I guess, in terms of what it is that we're talking about. And the first question I want to have around that is around the current evidence on postural management. Now, you just referred to then as well, that we've got wonderful systematic reviews have come out, and Aina Novak and her group who published that big systematic review of the traffic light system in 2020, they had postural management listed there under the sort of amber probably do it. I know you guys looked into this in a bit more detail in this paper now. Can you talk us through what are the things that make it an amber and what your thoughts are around that?
Well, those results were based on two systematic reviews that looked specifically at hip health and different positioning solutions, and one was Meling, which is a Dutch study. And the other one was Stacey Miller from BC Children's Hospital and her group that published, and one was 2017, one was 2018. And, they both included studies that were looking at sitting, lying, and standing. And there was quite a bit of overlap between the studies that they both included, and they're mostly reporting positive outcomes. But the issue is, of course, they're not randomized controlled trials. They're not large studies. It tends to be considered lower level evidence. And so then it gets downrated. And I mean, this is something that Ginny and I have talked about a lot, is what's the reality of being able to do the kind of studies that give the high evidence rating is really a challenge in this population. I'm probably getting ahead on the subject here, but that's, the reality is that these are the studies that have been able to be done. And for this population, these kids are very complex. It's very challenging to have them participate in research and to be able to maintain adherence to a protocol, because these are the kids that, they have to go, they're in pain, they have to go and have surgery, they have a pneumonia, they get hospitalized. The dropouts can be quite tremendous. And the other issue is that most of these kids need equipment in order to function. So there's all the ethical dilemmas of withholding or withdrawing an intervention. How do you set it up? Like even Ginny and I, in another paper we're working on, we came across a study, and it was in Pakistan, and they weren't allowed to withdraw the equipment because it was considered standard of care. And so if you can't do those kind of studies in a less resourced setting where postural management interventions are pretty new, it's going to be very challenging to do those kind of things. And so you always come out with its lower level evidence. And that's why we wrote this paper. Let's look at what is the evidence that's out there. We know what happens if we do nothing. Terrible things happen to kids' posture. And so what can be reasonably supported by combining the research evidence that's there, and with clinical experience, and with what families and kids want and are willing to participate in.
And I think what you just described there is essentially the definition of evidence-based practice, right? We talk about, let's try to find the highest level of evidence. And we know that there's areas in our industry where we don't have high levels of evidence. So we keep looking at what's the next one. And in this particular area, it does say it's amber, but then if we combine it with the needs of the families and our clinical expertise, we are doing a duty of care, and that's important. But I think one of the things that I loved in your paper that you raised was, even though it is amber, there are some things there that we need to make sure we put into place, and that's outcome measures, so that we are constantly evaluating what it is we're doing. We're not just doing what's next there because there's no evidence. We're actually making sure we take the extra step now and make sure that's in place. Now, you raised one, I've never heard of this one before, so I'd love you to talk to us about it, the posture and postural ability scale. Can you talk us through that? Because that was a bit of a recommendation you had made about this outcome.
We love it because it's free.
That means we love it too.
We're all about that.
Fabulous.
It's from Elizabeth Rodby Bosquet and Ginny Johns in Iceland and Athlete Augustin in Iceland, and it's following Pauline Pope's work.
Okay.
So it's valid, it's reliable, it looks at lying and sitting and standing. It looks at the ability as well as just what does it look like from the side and from the front. And it's a light switch. Either you got it or you don't got it.
Okay.
And it's purposeful because it's reminding you, start early, don't accept deviations, and stay true to the plumb line. Like, do the best you can. And it's easy.
Oh, that's great.
And something like that as well, to me, seems like it's a really good tool to raise awareness for families as well, in terms of the things that they need to be considering, because it's not just about the time spent in therapy. It's about, like you said, Ros, the 24 hours in a day and giving families as much support as they can get to really, make meaningful changes for their children.
And there's nice diagrams with it, so you can kind of show, right, here's where the issues are. And so the idea is, here's how the person sits, without their seating system, and then you fix up their seating system, and then you can rate them again and show that they have changed. I mean, the key thing with outcome measures is what outcomes are you going to measure? So, that one is particularly about alignment. But maybe the outcome that matters to the family is that they can, attend school all day, or that they can participate in some fun activity with their friends. So you need to look at what are the outcomes that are desired from that piece of equipment or that activity, and then to be measuring those, because if you're achieving the outcomes that are desired for that child, then that's an evidence-based intervention for them, regardless of what the group data shows.
And that goes back to the F words that you were talking about as well, constantly relating it back to that, that's your framework, and it's also where you can sort of really conceptualize your goals and your outcomes, therefore, from there as well.
Okay, so let's get into some of the specifics now from the paper. And let's start with lying position. I know we've touched on this a little bit already, but can we talk about, why it's important to consider position in lying and what the evidence tells us?
It's most important because we know from the Swedish data that the kids are spending about 16 hours a day lying.
Wow.
That's a lot.
That data is showing that only 1 in 4 of all adults with CP can only lie in one position. And that's about 50% when you look at GMFCS 4 and 5. And that's certainly, it's very common. And that's one of the reasons for thinking about starting younger, because one of the challenges we have is you have, someone who's reached their teens and they're quite asymmetrical, and then to try to change their sleeping position. Well, you know what it's like yourself.
Sure.
I was in a car accident and I had a neck injury and I couldn't lie in my usual position, and trying to sleep is a nightmare. So trying to change positions for these kids, it can be such a challenge. And that's why, Ginny works in early intervention, starting really early to try to promote being able to go in different positions is really, really helpful. But it comes back to sleep being kind of that primary outcome. If you don't sleep, your health is not good. It affects everything else. The research on lying is pretty limited, as we know. There was one small pilot RCT that was done, but only half of the kids, I think there was 14 kids, and I think 7 of them could actually use the sleep positioning system for the 1 year that they were following them. And some kids that experienced pain from sleeping were actually more comfortable in their positioning system. And this comes down to, I think, what's coming out of the Swedish data, and what they're recommending is it's not necessarily have to be these very rigid, structured lying systems. It can be simple supports. It's about finding comfortable and non-harmful positions and change in position where possible, and trying to minimize the long periods of time in one position that might be very detrimental.
And can we just talk for a second about what the kind of the detrimental effects of not changing position in lying are? Like there was something in the paper about wind sweeping and the impact or the increase in the likelihood of wind sweeping. Could you just talk a little bit about that?
Yeah, so that's Ottliet Augustin's paper. He did his doctorate with Elizabeth Rodby Basquet in Sweden, and he went through the CPUP database and found that the kids that slept in unsupported supine lying, Roz, give me the number. Is it 8 times more likely? I forgot what the odds ratio was. It's very high.
Huge.
Wow.
Of getting the windswept deformity.
So we know that the kids and adults develop contractures, and Erika Klut's paper has shown that knee contractures start first. Once you have knee contractures, when you lie on your back, Ginny was making the point that Attlee's paper talks about supine lying really contributing to this. Once you have knee flexion contractures, then your hips flex, and then the legs will typically go to one side. So that leads to the windswept postures. And then we know that long periods in like windswept hip position is associated with hip subluxation and pain, and the development of scoliosis, and all these things are linked together. So it's kind of a vicious cycle once you get into that asymmetrical position. And so, varying positions at night, if possible. Sometimes that's not possible because the person needs to be able to sleep. But we also see kids often spend long periods lying during the day as well. And for that, we'd really want them to be supported and perhaps be in different positions and more upright in more functional positions, if that's possible too.
And the solutions can be really simple. I think you have IKEA in
we do indeed.
Your hemisphere.
Yes.
They sell these long snake pillows that are fabulous. I have a mom in Japan who took 2 of the neck pillows that we wear on the airplane, and she looped one around each of her son's thighs to keep his legs apart during sleeping, but it wasn't enough to get in the way because he could move a little bit. So again, just these really individualized, what do you want to do? I use coaching in my practice. So tell me what you want to fix. What are your ideas to fix it? Because when you come up with the airplane pillow idea, you're going to remember to do it, and you're going to do it. And we'll talk together about what the point is and what are we trying to prevent and how can we make your son sleep better. But I really believe that when we work with that individual family and their strengths and we build their capacity, we'll have better outcomes.
No, that's wonderful. So I think what you summarised there with regards to lying is beautiful. We know that the evidence isn't very high in this particular area, but we know the challenges around that. We've spoken about outcomes and respiratory and sleep and all the things that we should be considering, and some practical considerations working with the family. And I think that's that's, really practical for us as therapists of where to go from there. So
I think so.
Yeah, thank you.
All right, so let's move on to adaptive seating now. What's the current evidence, and how should we be considering this in our clinical practice?
Well, the most recent systematic review, I think, was 2015, looking at GMFCS IV and V in particular. And, as with all the evidence, they concluded that, it was lower level evidence, but there was limited evidence of harm. Most of these children need supported seating in order to function, to ease caregiving, and to increase their activity and participation. And then when we look at Iona Novak's traffic lighting overview from 2020, again, she said weak positive evidence to improve postural support, improve hand function, pulmonary function, and pressure management. Yep. But there's no mention of hip stability as such. So there've been a couple of individual studies where they've looked at molded seating, and typically what's recommended is positioning and hip abduction. There's debate about how much hip abduction. We would generally say 10 to 15 degrees is well tolerated. I have had experience with kids who were really comfortable, with a lot of abduction, and you could actually kind of feel the hip go into joint when you position them that way. And so it's the problem with adaptive seating in this population is the population is so complex and diverse, and the needs are so different that I don't know that we're ever going to have big group studies that will show the kind of evidence that is going to rate well on these kind of rating systems. It's very much about what is needed for that individual in improving their function. But in terms of hip stability, we would generally say some abduction, some medial thigh support if they pull their legs together, supports on the outside of the thighs to prevent windsweeping, because again, kids will spend, or adults, they spend long periods of time in the wheelchair. Sometimes that's the only upright position that they have for function. When they go to school, they might be in the wheelchair for 5-6 hours a day. And so it needs to be comfortable, and it needs to hopefully prevent them being in those harmful positions. But most importantly, it needs to improve their function and their participation.
Yeah, really good point.
Love it.
And what you're saying just there comes back to, I think, one of the points that Ginny raised at the start about how much variability there is within, GMFCS level 4s and 5s. And so you really have to look at the individual picture and how you can best support the child and the family to be doing what they want to do.
And to measure the outcomes, because it's all amber all the time.
I love it. I absolutely love it. Okay, let's move on to the next one now, which gets me quite excited to talk about, because I feel like we hear about this all the time, and the evidence is not particularly clear, but there's some practical things again we can take from that. So supported standing, what is the evidence, and what can we do within our practice? I can see you, Ginny. Like you're rubbing your hands. I know I can see it. Yeah, go for it.
I have a secret. We have a new scoping review. Roz and I, and Lenore McLean is the lead author, on children at GMFCS Lauren 5, adolescents as well, young adults, just on standing, focusing on the lived experience.
So we'll be talking to you again soon then, hey? Whereabouts is that?
Breaking news.
Yeah, that's right.
Just accepted.
Oh, fabulous. Golly.
Well, that is very exciting.
Very exciting. All right. Well, obviously we'll need to wait for that paper to come about as well. But what do we currently know? Like if we're looking into literature now about supported standing, what is it that we're going to find there, and what can we use? How can we use that in our practice?
I think for me, the lessons I learned were when I went back to some of my families where the children are older now, and I said, hey, can you make me a video about how much you love standing? And they looked at me cross-eyed and sent me these videos about how much they hated standing. And that's what our paper said. Again, it's so individualistic.
Yeah.
the standard has to match the needs of the child and the family.
Yeah.
And I think one fun finding in one study was that the children or the adolescents reported being in the least amount of pain and the most comfortable when the therapists reported they were most aligned.
Oh, that's very interesting.
That's something that really came out was interesting in the latest paper. I would say, like, in terms of the evidence level, it hasn't really changed from the previous reviews. But I think the strongest evidence is still around impact on bone and mineral density and maintaining range of motion or contracture prevention. And, you know, the hip angle and position, you know, there's debate around should we be abducted. I think we're all agreed we don't want to be adducted in standing. That's not good for the hips. That at least 10 degrees of abduction is probably good for everybody when you're standing, just to align your hips. 10 to 15 degrees seems to be well tolerated by most. The papers about extreme abduction, I think the evidence is not really there. There's still a lot of debate around that issue, but you know, again, it comes back down to it's amber evidence. It's about promoting if the being in the standing frame promotes activity and participation and fits in the child's school program or the family lifestyle, if it increases their engagement in activities, if it lets them interact with people better or it makes them more functional, then it gets incorporated into their life. And if it doesn't, if it's just like exercise, then I think it's less easily incorporated. And that's a lot what our paper, you know, focusing more on the lived experience comes down to. Everything is a pro and con. It causes more pain, it causes less pain, it causes better posture, it causes worse posture. It's very individual.
But what's really cool is it's exercise. Like your metabolic rate goes up, you can train your heart rate. You think they're passively standing there, but they're not. It's part of their necessary 2 hours of activity a day.
We're laughing because we love that. And we've seen some.
And it looks like more is better. It looks like more is better. An hour is probably the minimum. There's one small study where when the kids stood for 2 to 3 hours a day over, was it 4 to 10 years, Roz?
Wow.
Yeah, 4 years. All the kids in that study were using a seating system with a pommel, and they were standing 1 hour a day, and they all maintained hip migration percentage under 40%. So it's kind of, it's sort of what the evidence comes down to about postural management in general. And Iona does talk about this in her paper, that the evidence for any individual intervention, postural management, surgery, medical interventions, none of them are very strong when it looks at prevention of hip displacement. But when you look at a combined program, they work together to when we're thinking about hip health in particular.
And when we're talking about standing, and we just touched on that being a form of physical activity for these kids, you know, naturally my brain then goes to stepping and supported stepping. So can we talk about supported stepping and what the evidence is for that?
Roz and I have had a great couple of years publishing articles on supported stepping. We started with a review, then we did outcome measures, then we did clinical considerations. We went into the lab at Georgia Tech and compared 3 different gait trainers, and then we published a case study on a child. So it's been really interesting to look at all that evidence and all the different things that people call these devices. We've sort of settled on supported stepping for now, but they've been called support walkers and gait trainers. We didn't like gait trainers so much because we felt like we weren't training gait. We were using this as a environmental modification and affordance for participation.
Oh, that's a really good point. And I mean, I love how you guys, I mean, when I look at the literature and I look at anything to do with supported stepping, your names always come up on that one, which is absolutely fabulous. And you know, thinking about the role of support to be able to take steps. And this goes back to what you said right at the beginning of the, you know, the variation GMFs level 4 and 5. You know, I've submitted papers before where they go, well, why are you working on stepping? Because these kids can't walk independently. And I'm like, well, let's go back to the drawing board here and let's have a chat. Because this is very, very possible. I mean, you know, we talk about in terms of physical activity. What do you guys have to say about what does the evidence say about, you know, dosage? I think that's a big part of it. And, you know, when should we be starting supported stepping in these devices? You know, what? Yeah. Talk me through that, Ginny.
We believe that it should be developmentally appropriate. So yes, typical kids are pulling to stand and cruising and maybe even walking by 9 months.
Yeah.
But they're setting up that experience even before that. So when we introduce a supported stepping device or a supported standing device at 9 months, it's already too late, because we know from Sean Williams that the sarcopenia, the disuse atrophy, is already set in at 9 months. The low bone mineral density, you can already see it in the NICU.
Yeah.
So it has to start way before we are doing it now. And we can tell which kids these are using the Hein and the general movement, the MOS, the higher end Brechtel. By 2 to 4 months age adjusted, you can know which is the child that's at highest probability of being at GMFCS 4 and 5.
Yeah.
So if we could know that back at 2 to 4 months adjusted age, then we can start with these interventions.
Yeah.
Love it.
Yeah.
I absolutely love it. I mean, it's sometimes that it's met with, just in my experience, it's met with resistance. You know, it's kind of like, well, let's do more handling. Let's do more of that kind of practice. And I kind of go, well, we're talking about 24 hours. We're talking about, well, you know, they're not walking all day, but there's only so many times a therapist can be with them to do all that stepping with them. You know, we're spending all this time on the floor rolling, but they're spending a lot of time on the floor anyway. So let's get them up, let's get them moving. And there's so many benefits from that. But yeah, it's met with a fair bit of resistance. And I'm really glad to talk to you about this.
Yeah, the rolling doesn't help with cognition. We know that from Karen Adolph.
Yeah.
And my analogy is, if a child is born without a limb, we don't wait to see if it's going to grow back. We give them a prosthetic. So why are we waiting? We need to give these children these opportunities to grow their personalities, their cognition now.
They need to be in upright positions, right, for their visual development. So, I mean, the evidence for impact on the hip, there is none. Like there are no studies looking at whether supported stepping devices impact on hip development. But, you know, in terms of bone mineral density, in terms of formation of the hip joint, you know, we believe that weight shift is beneficial. And the big issue for GMFCS 4s and 5s is reducing sedentary behavior and having a balance between different positions between sleep and wake cycle. And so we put stepping in here. I mean, I think that causes some debate, because I think traditionalists in the postural management wouldn't include stepping, but we believed it's important to include movement options that are appropriate for GMFCS 4s and 5s. And that's why we mentioned supported stepping, but other options could be cycling or run bikes or swimming. Or the big thing is moving and activity.
Yeah.
Love it.
And you had Mark Peterson on the show, and you heard what happens later in life.
That's right.
When you just have all that sedentary behavior.
Yep.
We got to get going sooner. We need to make it a habit.
Yep. Yep. The goal is future.
Yeah.
I love it.
Yeah. And I think that leads us really beautifully into the beautiful summary table that you have in this paper about the ages and the different management strategies that you can use within those different kind of age groups. So can we just kind of talk, like summarize the evidence and the clinical recommendations that have come out of your work?
Well, looking at that chart, we're really thinking about postural management in lying, starting as early as possible, because we know that those babies, and now that cerebral palsy and those who are at risk of being 4s and 5s can be identified very early, we can be looking at what position are they lying in and introducing that, like really from birth if possible, but certainly as they are identified. When it comes to adaptive seating, from at least 3 months, we want to get kids into more upright positions. We want to get them out of those baby bouncy seats. They need to be upright and supported so that they can be developing the eye-hand coordination, hand use, visual development, communication, and then into upright sitting by 6 months. For standing and stepping from sort of that 9 to 12 months, just thinking about the age appropriateness of that. And then thinking about all the other equipment that you use, because when we were thinking about hip health, it also impacts on what position are they being bathed in. If they're starting to use a potty or a toilet, they need to be positioned appropriately for those. When they're being transferred is often a big point. So many parents, there's a whole discussion about their hips. We need to keep them apart. We need to use the pommel. And then the parent picks them up, throws them over the shoulder, and the legs are together, and they carry them out. And you're like, every time they're picked up, if they're put, on the hip, if they've got the tight hips really pulled together. And then Ginny talks about hypotonia. If they're in that frog leg position instead, well, then you need to hold the legs, to get and be thinking about in all that equipment that comes to be part of these kids' lives.
So good.
And another important point is we know that in Australia, your rates of cerebral palsy are decreasing and your level of severity is decreasing, but that's not true everywhere else. In North America, we are actually staying the same or slightly increasing. And we know in some low and moderate resource countries, it's skewed. Much higher percentage of the children are more severe.
Yeah, that's right.
Yeah, it's a really good point. Yeah. So where to from here? I know you're both incredibly busy. You've got lots of projects on the go. Where is this work taking you?
We have a couple of things going on. One is hypotonia and hips right now in Europe and some of the other registries. Hypotonia CP is not a thing. So if you don't have ataxia and hypotonia, you're not included in the CP registry and you're not given access to hip surveillance. So we're really trying to change that. We would like hypotonic CP to be part of the lexicon so that those children have access to evidence-based interventions. So we're working on that. And then the clinical considerations. So we've got to redo the care pathway for hypotonia for American Academy of Cerebral Palsy based on the systematic review we published a few years ago. And then we want to do clinical considerations for standing as well.
Once we get the systematic review on standing.
Well, a lot to look forward to there. Again, I feel like we could talk for so long because I think this is it's so wonderful to have these clinical discussions and all the practicalities with it. But we do need to make sure we can wrap it all up nicely so that Ed can ask us questions. So we're going to head into the next segment now called Tell It to Ed. Now, Ed, as you know, is our producer. He doesn't have a background in child health, but he has been listening in on this conversation. And I think he's learned a thing or two. So Ginny and Roz, can I get you guys to summarize in about 60 seconds or so this particular paper and area of research, and Ed in turn will have time for a question. All right, take it away.
Okay. People with severe cerebral palsy need equipment to help them sit, stand, and take steps. And since it's so hard to move, their hips and knees tend to get tight. Lying down to stretch out and have a break from sitting sounds like a great idea, but they often end up stuck in harmful positions, like windsweeping, where the knees go together and the hips twist to one side, or frog leg lying, where the knees go out to the sides and the heels are together. And spending long periods of time in these harmful positions can lead to pain and other hip and spine problems. Lack of movement is harmful. Think about how you feel after a long flight. So it's ideal to find more than one lying position for sleeping, and comfortable supports can help, although being able to sleep is the most important consideration. During the day, you can break up the time spent in sitting by using a stander, by actively moving in a stepping or cycling device, or using a comfortable alternative type of seating system. Most important of all is to avoid long periods of lying without support on the back, particularly during the day, to encourage upright and active positions as much as possible, and to avoid positions that are harmful to the hips during all daily living activities like transverse bathing and toileting.
Oh, what a great summary. Loved it. All right, Ed, over to you.
I have to admit that every week we kind of do a podcast and I'm always kind of amazed at how often I constantly keep hearing the F words. And I think I've got a grasp of it these days. But I love the fact that obviously the science and research and all the evidence kind of builds and then we can make better decisions on these things. But I'm always really impressed with obviously the guests that we have on the show are constantly referring it back to families and their needs. And I'm still kind of in awe of the fact that we're kind of at this point now where maybe clinicians and researchers and the scientific community aren't necessarily liaising with the families and the wants and needs of the participant who might be receiving some therapy services. So I'm struggling a little bit to kind of understand why there is a disconnect there and what kind of needs to be done in that space to kind of help families and participants kind of have their input, but meeting their needs better as individuals. Because I love this scientific element behind it. And obviously you talk about it from a research perspective of that the evidence is not super high, or I'm just putting it in my own words there, sorry. And there are different grades of evidence and quality of research, but there are lots of people who obviously offer lots of therapy services and they're very definitive. And so they talk with great authority, it seems like, but it almost seems as though we're still missing the idea of participants and families actually getting out of therapy what they actually want for their life. And you talked about it from the future perspective for the F words as well. So my long-winded question is, what more needs to be done in that space to kind of bring that to a more holistic place?
For me, it's coaching. For me, it's the process of letting go that I know everything. One of my hobbies is arguing with people on the internet. It's not going very well.
Oh, wow.
And I think it's because it was lovely when I was the boss. It was lovely when I was in charge. I used to make kids walk. When I first started doing Move and putting kids in supported stepping devices for the first time, oh my gosh, that feeling was incredible. But it's such a better place now because I don't get that feeling anymore because someone did it before me. It's just part of standard practice. So my practice is totally transformed. I'm not putting my hands on your child. I'm not treating you. You're not my patient. We're a team. Tell me about your life. What can I do for you? And until everybody listens to your podcast, until everybody is convinced that participation is the way and that just when I touch you, your brainwaves change versus when your mother touches you. So to understand that I'm not helping you, that's not how we teach children anything. If I send you for soccer lessons, somebody doesn't have their hands all over you, correcting you and making you do it right.
Yeah.
Oh, I love that. That's such a great analogy. And that's actually really wonderful. So much food for thought there. Ginny? Yeah. Oh my gosh.
It reminds me of another piece of advice, just to come back a full loop. But it's like the more you learn and the more you know, the more you realize you don't know. And sometimes you have to kind of, hand that over to people who it's impacting. And I think, when we're talking about families in that instance, they should have a say in what's happening, and it needs to be something that is meaningful and important to them. Yeah. So
it's humbling. And I think it just comes down to the fact that it's not actually about us. Like, I'm your therapist, but it's not about me. It's not about how it makes me feel. My role is to facilitate and to help you live the best possible life. And I just facilitate. What can I do to help you? But what's ready in your life? And it's a great job, but it's not about me. And I think you guys have both brought this home so nicely.
Yeah.
Oh, goodness me. We can't wait to talk to you guys again when your next paper is out. So thank you so much for staying up late, missing dinner time to chat with us. It was just, we had the best time. Thank you so very, very much.
Thank you so much. This has been such a thrill. I love your work. Keep going. Let's change the world.
Oh, love it.
Love it, Ginny.
Thank you so much.
Thank you.
Yeah, a huge privilege to speak to you both. So thank you again for your time.
Yeah.
You can go to bed now.
All right, to all our listeners, remember you can get a hold of the run sheet notes, and we'll try to put some links of some of the papers we talked about as well, particularly the outcome measure. So head over to researchworks.net, and remember there's a CPD form there that you can fill out to keep this as part of a record of your PD requirements. But for now, we say thank you so very, very much, and we'll talk to you all again next time. Bye.
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 Bye.